So this is my last talk, and I'm really grateful and happy to participate in this meeting. The topic is advances in diagnostics for corneal ectatic diseases, and this is probably one of the most important talks and contributions that I have. Of course, I have a contribution and collaboration with Oculus, and it's my honor to do that for over 15 years. I also have a master class on this topic with over 20 hours of talks related to this, but it's always been a dream to know Greece because I'm a very uh, big reader and learner from the ancient philosophy. So thinking about Plato's wisdom, we have to understand what we have justification for, what we believe on, and what is the truth, and eventually understanding the idea that the scientific thinking and belief and knowledge is something that we consider for many, many years, over 2,000 years ago. So when you think about diagnostics for keratoconus, we have to think in this and understand how we can do the diagnostics and what we're trying to achieve. And we have multimodal imaging, for example, with the Pentacam, now with axial length and ocular wavefront. But the basic understanding of enhanced ectasis is to combine elevation, front and back, and thickness profile, along with the deviation from normality. But we also have the progression display from Michael Bellin, which would look at the statistical significance from the baseline, considering the thresholds of the repeatability of the measurements in a keratoconic population for the front surface, back surface for the thinnest point, and D is related to distance correct vision. And I will talk about the E, which is coming from biomechanics, from the elasticity of the cornea. But all this has been related to progressive ectasia after laser vision correction. The first two reports from Professor Siley in 1998, the 3 cases with progressive ectasia in high myopic LASIK. And a few months later, he published the forme fruus keratoconus as a cause of ectasia due to the biomechanical weakness of the cornea prior to surgery. And he defined forme fruus based on the stiffening of the cornea based on topography. This 2 reports allude to the pathophysiology of biomechanical compensation, the innate biomechanical properties, the impact from the environment, and of course, eye rubbing, aggravating of aggravated by laser vision correction. But eye rubbing is the most important factor today, and any cornea may develop ectasia. They're going this cycle of biomechanical decompensation, very nicely described by Cynthia Roberts and BJ Dupes. This is important to relate to the Violet June campaign. Eye rubbing is bad for you. That's a very general statement, but any cornea surgeon would benefit from understanding that eye rubbing can aggravate keratoconus and may even cause ectasia. This is not the same thing, and I hope you understand what I have in my mind behind it. But the Violet June campaign also is related to the patient education project, and misinformation can make the patient suffer even more than the disease itself, not only the patient, but the family and whole society. So topography is important because you can detect mild abnormalities in patients with mild disease, 2015 distance corrected, 2025 minus, plus, and in these cases, in this half of the cases that we saw in Seattle, Washington, at the University of Washington, had a normal biomicroscopy and a good distance correct vision, and they present with mild topographic abnormalities. The ectasia risk score system by Brad Redmond put topography in the top of the list. He also adds age, which is a surrogate of corneal biomechanics, and any refractive surgeon should be relatively comfortable for reading corneal topography maps. My main concern is the forme fruus keratoconus as a synonym for abnormal topography. Forme fruus keratoconus was defined as an incomplete and abortive form of the disease by Mark Emsler 50 years prior to topography be available. Forme fruus is also coined in other medical terms like forme fruus psychosis by Sigmund Freud. And the forme fruus keratoconus is defined by Aaron Rabinovitz as a case with abnormal topography from a patient that has good distance correct vision and almost slit lamp. Interestingly, Steve Kleiss would add the fellow eye with a normal topography, sometimes related to unilateral disease, but I would say it's a little superficial to say it's unilateral, but those cases are better say as very asymmetric ectasia cases, and we learn tremendously from those. There is no consensus on what is form fruus keratoconus. It's important that we try to define it, and my humble contribution is that this is not a topographic classification, and form fruus is a very susceptible case for ectasia progression, and we quote that for the first time in 2008. This is the paper that we sent to the American Academy of Ophthalmology. That time we were discussing about cases like this one. This was presented by Doug Koch, and this patient had a little bit of a yellow here. There's a Steve Kleiss 1.5 diopter scale. The PTA was relatively good. There was no PTA description that time, by the way, but the residual stromal bed was 304, and this case had ectasia after LASIK with a thin flap, subbauman keratomiliosis. Interestingly, this case lead us, because a lot of people would say that this little yellow here would say a pathognomonic for form fruus keratoconus, and I was really motivated to do this study. We sent topography maps, 25 topography maps to 11 experts, all of them fellowship trained corneal refractive surgeons, and the variability was huge from 0 to 3, and the mode was 0, asking the colleagues to do the same work for the same cases, but with a different scale. Here, case number 6, varied from 0 to 4, but still the mode was 0. This case was retrospectively seen. In 2008, we didn't have a better Lombroso display that time, but the retrospective calculation from the U12 files lead us to a low art max and a high D, and those are the thresholds that I would consider for ectasia susceptibility. Interestingly, SMILE can cause ectasia, and there's a biomechanical advantage in terms of LASIK, I do believe that, but this case was a very interesting one because the patient had a low K keratoconus. You see all the parameters, and if you want to memorize a table, that's one of the tables that you should have from this letter, because you have the cutoff, the sensitivity and specificity for most of these parameters, and this patient had unquestionable keratoconus, even though the Kmax was relatively low. So this is a low K keratoconus, which happens in about 8 to 12% of clinical keratoconus cases. The enhanced ectasia study, we looked at 105 pre-op data from patients that had ectasia after LASIK, comparing to 3,278. And you see IS value, the classic asymmetry between superior and inferior part of the cornea, is very specific, but not so sensitive. We have less than 25%. The D, which was not available when these cases were performed, was sensitive to detect about 60% of cases. But if you improve the artificial intelligence with the pentacam random forest, you can improve that significantly from the bad D. Interestingly, you still have cases down here, and leads us to the need for more data. More data can come from the surface epithelial thickness data, from high-frequency ultrasound, the great work pioneered by Dan Breinstein with epithelial thickness data. We have machine learning data that he published in the LVS that can be very useful. However, that's no external validation so far published in the literature. Interestingly, we also have segmental data from OCT, which has definitely popularized the epithelial thickness profile maps, which can distinguish keratoconus from warpage. For example, cases with inferior stiffening, you can see thinning in terms of ectasia and thickening when you have corneal warpage, and that can be nicely seen by the epithelial thickness maps. But the data is to go beyond, not over, architecture, geometric characterization towards biological properties, and I'll divide that in terms of wound healing and biomechanical properties. The quote by my colleague from Brazil, Roberto Oliveira, a very experienced refractive surgeon, would say that the biomechanical measurement is a node measurement from the times of RKA, but we never had it available. But the data is available today. The dynamic shine fluid imaging can take in 31 milliseconds, 140 frames. And the idea is to do an objective measurement of the cornea, looking at the deformation, the velocity, the shape of the deformation, and we can combine this data with the CBI. Very, very nice work done by Ricardo and Paulo Vintiguera, which we are very honored and proud to collaborate with. And this can distinguish from a softer and a stiffer cornea based on the shape of the deformation, and including some of the geometrical parts of the cornea, because you have horizontal thickness with the Ambrosio relational thickness at the horizontal axis. Our idea, though, is to combine tomography and biomechanics, and this includes more sophisticated artificial intelligence The CBI is based on linear regression analysis, but for the combination of tomography and biomechanics, you need random forest as was the best approach. And the tomography and biomechanical index can distinguish 90.4% sensitivity with a cutoff optimization with more than 4% false positives in the original series published in 2017. All those cases were relatively normal on topography based on very strict criteria. Interestingly, this is a representation of epithelial of corneal biomechanical susceptibility. So if we add epithelial thickness data, probably can maybe improve this algorithm. But I already mentioned about this case, which is a unilateral ectasia case. Everything was normal when the follow-up in the left eye based on epithelial thickness is the Young-Gatinel score analyzer, and retrospectively calculating from 2014 the shape deformation here. This patient had a very low TBI. He comes back a few years later and the TBI was still normal. So it's unilateral ectasia. But the idea is that true keratoconus does not exist, but unilateral ectasia can be a biomechanical induced consideration that you can also have. So unilateral ectasia is possible. So there's a report here. The 13-year-old patient comes with asymmetric ectasia. The left eye has 20/60, the right eye has 20/15. This is correct vision. If you change the scale, very, very normal topography. How can you use exams to help? Exams can help you to see biomechanical susceptibility of Fru's disease in the right eye with 20/15. Also, you can use the data for the left eye for prognosis. This has very low stiffness parameter at the first applanation momentum, and this would be a very important sign of a very risk for ectasia progression, because it tells us that the cornea is very weak. And interestingly, when the patient comes back 6 months later, you see a reduction of Kmax. You see reduction of Kmax, but if you compare the second exam from the first exam, you see stiffening here, which is unquestionable, and you see there's more red here than here, and that's the subtraction map. But it's more objectively seen when you see the ABC from Michael Belling. You have a significant change from the A and B, and almost in the C, you have this reaching very important statistical significance. So now the patient really needs, there is no question about it, for doing cross-linking and eventually later a corneal ring procedure. The last evolution is to include biomechanical E-Staging. This was a very nice project led by Professor Belfeld Seitz from Hamburg, Germany, and with his group, Elias Flokenzi, along with Michael Bellin, Paulo and Ricardo Vinciguerra, and myself. And we have the E now, which nicely correlates with the progression of ectasia. So I do think that we have different aspects for the diagnosis, and multimodal corneal imaging for ectasia would be very, very related to artificial intelligence, more data, applying the artificial intelligence with some wisdom with artificial intelligence applied with ancient intelligence for understanding the patient, for customized planning, for seeing the results, for the diagnosis of ectasia. And the diagnostics would be related to the understanding of the characterization of biomechanical susceptibility, which is related to the topic of screening ectasia risk prior to refractive surgery, but is also important for diagnosing, staging the disease, prognosing, saying the patient has more chances for needing surgery, for having a better or a less favorable outcome, for classifying the disease. Eventually, keratoconus and ectasia can be separated based on multimodal imaging. And of course, clinical follow-up is very important for these cases. So refractive imaging is a true revolution in evolution, and all of this data should be understood by the physician so that we can use data since the anamnesis, asking the patient if they rub the eye, understanding about allergy, slit lamp is always going to be very important. Central corneal thickness, placido disc topography, ocular surface imaging, 3D tomography, the Scheinflug, and also with segmental with OCT, high frequency ultrasound, ocular biometry to understand if the myopia is axial or if the patient has more corneal myopia, wavefront and quality of optics data, IOP and corneal biomechanics, very important role of biomechanics for understanding IOP, specular and confocal microscopy, and of course, the future molecular biology and genetics. So again, this is multimodal refractive imaging, and thank you very much for the honor and opportunity to share my ideas with all of you. And I really hope and look forward to collaborating with you in the Violet June keratoconus awareness campaign in 2022. So thank you very much, and I really appreciate your invitation, and I'm sorry for not being with you. Thank you again.